Dear colleagues, I faced floppy iris in this case and I could complete this surgery without using any pupil expansion device. Let us see how the surgery goes. Here is the main incision, 2.8 millimeter main incision. We can see this is a soft cataract. Viscoelastic substance 2% HPMC has been injected into the anterior chamber. Now one side port is made on the right side of the main incision and another side port is made on the left side of the main incision. The eyeball is supported with a cotton tipped bud. That's it. Now capsulorhexis is to be done. The anterior capsule of the cataractous lens is incised with a 26 gauge bent cystitome. Then I use a itraoperative forceps, hold this capsular tag. I go anti-clockwise with my right hand and I do this continuous curvilinear capsulorhexis. This is a fairly round rhexis. Pupil is dilated, quite well dilated at this stage, and I didn't expect any problem in this case. Now hydrodissection is done. Now as I do hydrodissection, I could make out that the iris will not behave normally. It is going to be floppy and it is going to cause problems in my surgery. Here it is. I go into the antechamber with the phaco handpiece, and as I start sculpting, see what happens. The pupil becomes very small, iris tends to prolapse to the side port, but I continue and I could make a partial slice of the nucleus. I rotate the nucleus 180 degree. Good that I did that. I rotated it 180 degree and I go to a deeper level. I sculpt and go to a deeper level. My aim is to divide the nucleus into two halves, and I could do that, but as I continued emulsifying these fragments, people became smaller and smaller, and I was afraid to continue. See, the pupil has become so small, I am afraid that I will catch the pupillary margin at any stage of surgery, at any moment of the surgery. So what I do is, I decide to come out. I decide to come out. I inject viscoelastic substance so that pupil enlarges. This viscoelastic substance will cause some dilatation of the pupil. Now I use two instruments, one chopper in my left hand, one Sinskey hook in my right hand, and I ensure that the nucleus has been divided into two halves. I rotate and I place the thicker mass inferiorly, and now my aim is to do surgery with one hand. I don't want to use the chopper because as I use the chopper, fluid will come out through the side port and iris will tend to prolapse through the side port. People will become very small. If I do surgery with one hand, I may be able to complete this surgery. Now here it goes. I have decided to do surgery from this stage with one hand. Now I am trying to pull the nuclear mass to the center of the pupillary area, and here it is. I could do that. Now I rotate the handpiece so that the nuclear mass can easily come to the port of the handpiece. Now I make the bevel little down so that this piece can get engaged to the tip. I am very cautious not to catch the posterior capsule, and as the nuclear mass comes, I make the bevel off. So it has been just a play with the phaco tip, sometimes sideways, sometimes down, sometimes up. Thus, I could complete this emulsification of the nucleus with my right hand. Now I am using a Simcoe cannula to remove the cortical matter. I can go behind the iris and I can pull the cortical matter. When the floppy iris, when the iris is floppy, this coaxial or Simcoe IA is better than bimanual eye, because if you use bimanual, the iris will tend to prolapse through these side ports and the pupil will become smaller. Here it is. The cortical matter has been cleaned nicely. The posterior capsule is clean. There are no cells sticking to the posterior capsule. And now I inject viscoelastic substance, HPMC, fill up the capsular bag and antechamber and implant a lens, a 4-level intraocular lens in the capsular bag. This is Technis 1 from Abbott. This is a aspheric hydrophobic intraocular lens. Now I rotate the lens and ensure that it is in the capsular bag with this Y-shaped instrument. I can push the pupillary margin. I can push the lens, align the lens as I want. I can check whether the lens is behind the rhexis margin, and thus when I am assured that the lens is in the bag, I start removing the viscoelastic substance. At this stage I am just irrigating. Now I am using irrigation and aspiration both for removing the viscoelastic substance. Thorough removal of viscoelastic substance is a must so that the patient remains comfortable, intraocular pressure doesn't rise. Now I want to go behind the IOL and irrigate the area behind the IOL, that is the capsular bag. Lot of visco remains there, so I removed that, again used irrigation and aspiration together, and thus I did a thorough cleaning of the viscoelastic substance. That's it. Now the side ports are hydrated and the anterior chamber is formed with BSS and the case gets over. Dear colleagues, we must understand a situation and we must face challenges, accept challenges and complete this surgery. Thank you for your attention.